Welcome to OncoPharm. I'm your host, John Bazzara. I am a professor of pharmacy practice at ETSU's Bill Gatton College of Pharmacy. And OncoPharm is sponsored by Kelly C. PharmD, an oncology education company for pharmacists. Today I want to talk about the approval late last month, so this would have been late March of 2026, of Relacorilant, which is the brand name Lifyorli. Relacorilant. That's what was approved. And these are capsules, and this is a glucoCORticoid receptor antagonist that was approved in combination with nab-paclitaxel for metastatic recurrent ovarian cancer. So epithelial ovarian cancer, fallopian tube, primary peritoneal carcinoma. These had to be platinum resistant, and they had to receive at least 1 to 3 prior treatments, including bevacizumab. So a glucoCORticoid receptor antagonist, this is a new class kind of of medications as far as we think of it for cancer. And so the rationale here is that when cortisol binds to the glucoCORticoid receptor, that there is some innate immunosuppressive effect. We know the immune system is really important for treating cancer, and this leads to a decreased secretion of cytokines that can negatively impact the immune system. And in some preclinical models, Relacorilant inhibited the cortisol-induced reduction of TNF-alpha and interferon gamma in immune cells. And this is from the PI. You can go look in the primary literature in the preclinical data and see that Relacorilant in combination with taxane can restore some of the resistance to taxanes, which is kind of the rationale for adding it here with nab-paclitaxel in ovarian cancer. We'll get back to that. But the first thing I want to go over, I don't need to do this, I don't need to have the podcast, but there's some warnings obviously about adrenal insufficiency. If you have somebody that's on systemic opioids for COPD or from immune-related adverse events, you cannot use this drug because you could exacerbate those conditions if they need corticosteroids for life-threatening conditions. There are some potential drug interaction potentials we'll talk about. The drug does have better absorption with food, so it does need to be taken with food. And the dose is 150 milligrams, and this is going to sound familiar for taxane folks, but not for nab-paclitaxel folks. You have to take 150 milligrams by mouth with food the day before, the day of, and the day after. So very similar to some of the dexamethasone dosing with docetaxel to prevent edema. So this is the day before, day of, day after is not uncommon. The drug has a half-life of 25 hours, but its effects could last even for a week after that systemically as far as blocking the effects of the glucoCORticoid receptor, which is important if folks got, say, sepsis and neutropenic and needed steroids early on. They may be less responsive because of this drug. There are not a lot of dose reductions for toxicity for Relacorilant. If basically everything you can think of that would be a main toxicity of nab-paclitaxel, you reduce the dose of nab-paclitaxel. If it's an off-the-wall toxicity, then you can reduce the dose from 150 down 1 dose level for this. If we look at the side effects here, you're going to see that there's not a ton of unique side effects of Relacorilant with nab-paclitaxel. And this is from the Rosello study. This is the randomized controlled study that established the efficacy of the drug. There's more fatigue when you add this drug, so 54% versus 45%. Doesn't sound like a lot, but when you look at grade 3 or 4 fatigue, it's 9% versus less than 2%. That's a sizable difference. We see a little bit more nausea, a little bit more diarrhea, a little bit more stomatitis as well. We see rash of 24% versus 10%. Grade 3 or 4 rash is 3.7% versus 0.5%. You're kind of maybe seeing some side effects here of these side effects wouldn't be there if we could use steroids. Decreased appetite, 22% versus 12%. Cough, 19% versus 15%. Dizziness, 13% versus 4%. You know what happens when you don't have any cortisol. You've seen someone on Pembro long enough, you'll see folks, if you see enough folks on Pembro long enough, you'll see some adrenal insufficiency. They can get dizzy if their cortisol is low. Dysgeusia, 13% versus 5%. So we do see some more toxicity. It's somewhat notable, or somewhat maybe minor. As far as myelosuppression, neutropenia, 74% versus 64%, 65%. Grade 3 or 4 neutropenia, 44% versus 27%. Quite a bit more neutropenia. Thrombocytopenia, 28% versus 14%, twice as much. So we do see more myelosuppression, which, what would blocking the glucoCORticoid receptor how would that lead to more myelosuppression? It's almost like what we're actually seeing is more nab-paclitaxel toxicity. This leads us to the drug-drug interaction potential of the drug. So, this Relacorilant is Relacorilant. Relacorilant. This is a hard one for me to say. Relacorilant is an inhibitor of CYP2C8, CYP2C3, and CYP3A4. So paclitaxel is metabolized by CYP3A4 and primarily CYP2C8. And when you give paclitaxel with Relacorilant, you see the AUC is increased about twofold and this is paclitaxel, not nab-paclitaxel. Now we have phase 1 studies of nab-paclitaxel with Relacorilant, and when we look at our phase 3 study, we are looking at a dose of nab-paclitaxel with Relacorilant, which is 80 milligrams per meter squared on days 1, 8, and 15 of a 28-day cycle. And the comparator group is nab-paclitaxel by itself, 100 milligrams per meter squared on days 1, 8, and 15. So if we think this drug increases the exposure of conventional paclitaxel twice as much, nab-paclitaxel are getting 20% as much. So is this blocking the glucoCORticoid receptor actually improving the response of the cancer to nab-paclitaxel, or are we just getting more taxane? Is it just a pharmacoenhancer? It's kind of hard to say. The dose of the 100 milligram per meter squared of nab-paclitaxel is the cited dose in the refractory ovarian cancer population, which we should talk about. So our favorite guidelines for ovarian cancer in the recurrent setting list these preferred therapies: oral cyclophosphamide and bevacizumab. They all had to have received bevacizumab. Docetaxel, gemcitabine, liposomal doxorubicin with or without bevacizumab. It's always with or without bevacizumab. Paclitaxel, with or without bev. Topotecan, with or without bev. The prior treatment these patients had received, and I said gemcitabine in there, the prior treatments that these patients had received included bevacizumab in all cases, taxane in all cases, and you could criticize doing nab-paclitaxel after they've had taxane, absolutely, but their taxane was probably early on in the carbopaclitaxel, way early on in treatment. Might be reasonable to re-challenge with taxane, although nab-paclitaxel is an other recommended, not one of the preferred treatments. They chose nab-paclitaxel because if you gave conventional paclitaxel, you'd have to give dexamethasone, and so they're kind of testing this theory that blocking the cortisol receptor or the glucoCORticoid receptor, they're testing that hypothesis here. And if you gave a whole bunch of folks steroid, you could argue it would have been unethical because that's their central premise here. The argument is blocking this receptor is good for restoring the sensitivity of taxanes. Liposomal doxorubicin, 65% had received, PARP inhibitor, 60%, mirvetuximab soravtansine, I can say that one easily, is 2 to 3%. Probably a little bit more patients than that would have received that in the real world in this setting. No one looks like they got topotecan or gemcitabine. That's not reported, which makes me think this is not very generalizable to what a lot of folks are doing in the advanced ovarian cancer space. As far as the endpoints here, we see a modest, a squeaky improvement in median progression-free survival from 5.5 to 6.5 months. That hazard ratio is 0.7. Our 95% CI is 0.51 to 0.91. So there's a little bit of benefit there. Our OS benefit is a little bit more, median OS of 11.5 versus 16 months. Hazard ratio 0.69. 95% CI, 0.52 to 0.91. Those Kaplan-Meier curves don't separate at all for 5 months. So it looks like this drug has some modest benefit. I do think you really have to wonder about the comparator here, and does that help a whole lot? Is that showing us something? This is a study of fewer than 400 folks, which is, I think, a reasonable sample size for 1 to 3 prior lines of treatment in metastatic ovarian cancer. So it is an added approval. It's going to be probably a specialty drug. It's going to come in a blister pack that's got 300 milligram capsules and then 6 25 milligram capsules. It's going to be laid out, so like here's your day 1 dose, everything's there. There's your day 2 dose on the day of chemo, and then your 3rd dose the day after chemo is going to be there. And then you got to think about your antiemetics, because we would not be using taxanes with this regimen as antiemetics because of the Relacorilant and that glucoCORticoid receptor antagonist that's part of this regimen. So that is the approval of Relacorilant. And a lot of listeners to this podcast, they tune in because they're new to oncology. They're trying to keep up with the speed of new approvals like this. Or they just appreciate quick weekly updates to help keep pace with the onslaught of new information in oncology. If that sounds like you, check out Oncology Insights newsletter, a free weekly email written by fellow Oncofarm Kelly Karlstrom, founder of Kelly C. PharmD in the ELO Collaborative Program. Each week, she shares practical pearls, ways to think through oncology concepts without just memorizing guidelines, and insights on staying motivated and growing in your practice. It's written by a pharmacist for a pharmacist, and it's easy to read. You can sign up using the link in the show notes. Just scroll down in your Apple Podcast app or Spotify, and you'll see it there in the show notes. All right, the last thing I want to talk about was the final analysis, they say, of the initial one of the initial CLL studies of ibrutinib. And so I remember talking to one of my favorite oncologists I worked with ibrutinib first came out, and he said, John, with all these accelerated approvals, I would love to write something. I'd love to figure out a way of how you can predict, based on an accelerated approval, how good a drug is going to be. He said, I'm convinced ibrutinib is going to be a game changer. And he was right. He was right. It was a game changer. It completely changed how we think of CLL. And there were some that thought maybe BTK inhibitors could do to CLL what BCR-ABL inhibitors did to imatinib, or what imatinib did to CML, and make it into a one-drug disease. That has not turned out to be the case for CLL. We do see a lot of undetectable minimum residual disease with some of these patients on BTK inhibitors, and if we are more intensive in what we add on to it, like venetoclax or obinutuzumab, we can reach pretty high levels of undetectable MRD, but at the cost of some infectious toxicity, especially in a population that's a little bit older and probably more susceptible to those infections. And so this is, the 10-year report of this investigator-initiated phase 2 study. There's a nice editorial. This is published in Blood. Just came across my email right before I started recording. And one of the things that is notable here is our PFS curve for these 84 patients and our OS curves. There's no plateau. They just kind of go down. Maybe you can start to see a little bit of a plateau once you get to 7 years. The OS just continues to go down. It's an older population, but we don't see that plateau that we'd like to see. That tells us we're not, from year after year, we're not seeing any higher risk of progression of this cancer or of death. So certainly very good drugs, but it's, I think, always nice to take a step back, look at the long-term outcomes, and see what we're seeing there. So obviously CLL has changed a whole lot from the FCR days, of 20 years ago, and ibrutinib has largely been phased out of everyday use, with our later generation BTK inhibitors like acalabrutinib and zanubrutinib, which seem to have probably the same efficacy, but are much safer, lower risk of hypertension, lower risk of atrial fibrillation and arrhythmias. So we're not going to see probably a lot more ibrutinib studies, but somewhat like imatinib, probably will still have a role once, maybe as the earliest one, the first one to go generic, and the cheaper one to use, and still has, and is still pretty good. I think you could make an argument we should maybe do ibrutinib first line, and if they have trouble, toxicities, then do the other more expensive drugs once we have access and are using generic ibrutinib widespread. That may be the stewardship play. Okay, that is what I have for you this week. Thank you so much for listening. You can follow me on X at Farndietnib and on other social media platforms at OncoFarmPod. And until I talk to you again, remember, doses matter.